this hopefully every 7 to 10 days for now. My partner, who's an infectious disease doctor like I am, Dr. Dan Rodrigue, has kindly agreed to do this talk and regularly update it. We also have Dr. John Barton here today. He's a high-risk OB doctor here who's nationally recognized and helping write the guidelines for obstetrics in the COVID-19 era. Those are supposed to be out next week. Dr. Rodrigue and Dr. Barton are both going to discuss some issues regarding that in the talk. Initially, Dan Rodrigue is going to summarize his talk from last week and then talk about new issues that have come up. Dr. Barton will talk shortly after that, and then there'll be a question and answer period. We'll plan to do this again next Friday. Here's Dr. Rodrigue.
Okay, I'd like to go through the slides, but here is the first slide. And the saying is, now is the time to understand more so that we may fear less. Because certainly in these types of situations when we're experiencing an outbreak of this magnitude, people are anxious, they're fearful, they're saying, you know, they don't know what's happening, what's going to happen to them. And it affects all of us as healthcare workers. It also affects our families. So let's learn a little more about this to deal with it. Here's a shout out for moms that are now homeschooling, and it somewhat touches on maybe the state of what people feel like at home about this outbreak. This is a child who's saying, it is not going good. My mom's getting stressed out. My mom is really getting confused. We took a break so my mom can figure it out. And I'm telling you, it's not going good. Well, our job today is to kind of review stuff that we do know and apply those lessons toward this outbreak so that we can handle it better and take care of our patients and ourselves. Some of these slides, what I'd like to do eventually is to have this up on a website so that you can take a look at them. You don't have to put stuff down. The talk is being recorded, so we'll move forward. Coronavirus is not a new virus, really discovered in the 1930s in animals and then discovered in the 1960s in humans, and called coronavirus because of the projections off the virus itself. It is a ubiquitous virus. It's found broadly around humans and animals, and really didn't come onto our radar because it caused a relatively mild illness, 15% of respiratory illnesses yearly. Reinfection can occur as antibody levels decline, and the primary routes of transmission were contact and droplet, but aerosol transmission was also reported. So the big news about coronaviruses was fairly benign until we had two outbreaks in the last decades or so. First one, SARS, which started in 2002, and it started to give us insights that there are coronaviruses that have an animal-human connection that have significant outcomes with worse mortality. The last case to SARS, however, was back in 2004. So each time we go through some of these outbreaks, we have learned about how to deal with it, how to deal with the PPE, how to deal with the treatment issues, et cetera, working on vaccines, which have been worked on but not come to market yet. But there are actually trials looking at, for example, MERS vaccines, but they haven't come to the public yet. But SARS burned out in 2004. Then we have MERS, identified in a young man from Saudi Arabia, also a animal-human connection. Most of these viruses that we're talking about today, whether it's SARS, MERS, or SARS-CoV-2, originate in bats and then have an intermediate host. The intermediate host in the MERS outbreak was the dromedary camel. Case fatality in that outbreak was much higher than SARS, but again had an interesting finding that patients could be asymptomatic if they were younger. This is typical for outbreaks. They start in an area and then they spread depending upon the characteristic of the organism, the modes of travel, And this represents the MERS outbreak that started in the Middle East and then spread. The United States only had 2 cases. So it brings us to COVID-19. In December 2019, the pneumonia cases, which were initially unrecognized in terms of a novel pathogen, emerged in Wuhan, and then it was sequenced as a novel coronavirus that was named SARS-CoV-2, and it was named SARS-CoV-2 because it had probably about a 70% homology with the old SARS from 2002. The outbreak started, at least reported here. I don't know if you could see the marker, but it was reported around Christmas time, and then closing of the Hunan seafood market in the beginning of January, where they traced cases to, and then notification and WHO declaring a public state of emergency, and then a pandemic on 3/11/20. The beginning cases still hold true in terms of some of the aspects of this illness. So initial reports out of China were that the majority of cases were mild, but you did have a spectrum of cases that were severe, 14%, and the case fatality rate of 2.3%. But notably, those that were over age of 80 had a much higher percentage of being ill. And if you were critically ill, you had a fairly high mortality rate, almost 50%. Healthcare personnel were recognized as being part of the outbreak in the beginning. The Wuhan case, the whole overall outbreak in China was reported to have 3.8% of healthcare workers, still 1,700 workers. But of note, most of the healthcare workers that got sick were in Wuhan. They weren't in other, as this spread to other parts of China, the healthcare worker percent in terms of who gets infected really went down. And that's an important lesson, again, to look at what circumstances lead to us as healthcare workers getting infected. Healthcare workers, so 3.8% in the Chinese outbreak, but if you look at some other outbreaks that are reported in case series, in one center in Wuhan, 29% of the cases were healthcare workers. And in Italy, up to 20% of the healthcare workers were getting infected, oftentimes associated with breakdown in PPE, the correct use of protection, the correct infection control. And there are probably some other factors involved that are not really well described in the papers. For example, when you overwhelm an ICU, when you overwhelm a hospital, and you have such a high case load, there's multiple opportunities to getting infected. It's not only in the hospital, it's probably in the community. So while you may do perfect PPE in the hospital, you may still get infected because there's a large number of people in the community infected. So globally, when you look at numbers will change. I mean, they change every day. It's hard to keep up with the numbers. So you'll be one day behind and say, no, that's incorrect. It's actually, 500,000. Well, okay. Try to keep a relative idea that every day things do exponentially increase, and then they have their different peaks and valleys. This epidemic started in China. They really had a big peak of 80 some odd thousand cases, and then is tapering off in China. Globally, however, the outbreak has spread to the European countries, and they're on a crescendo, especially Spain and Italy. And the United States now is starting to take off. And if you watch CNN or other news stations, where we now have more cases than China does. But that will change over time. The absolute numbers will change. It will change depending upon which site you look at. Probably try to stick to one site. You can use Johns Hopkins, you can use cdc.gov, you can use who.int, but stick to something to try to keep your numbers straight. The case fatality rate still 2% or so, depends on multiple factors, which populations are getting infected. But for most of the outbreaks and most of the papers, and at this point, there's probably over 5,000 papers published on this, mostly not peer-reviewed yet. The age is a risk factor, over 60, comorbidities with chronic diseases like COPD, diabetes, coronary artery disease, chronic kidney disease, cancer, and immunocompromised hosts. And the incubation period, we say, is 2 to 14 days. There are papers that are going to say the incubation period in our outbreak was 3 days. The incubation period in our outbreak was X, but it's all around similar points. Most of it is 5 days. There's a span of time that you can get infected, but 14 days is thought to be a reasonable date to look at. This also probably originates in bats with crossover. And here's the outbreak curve in Italy that predicts, this is early on in their outbreak, predicting that they'd have 30 some odd thousand cases by middle of March. If you look in terms of what happened there, this is by March 27, they have 74,000 cases, 7,500 deaths. Most of that was in northern Italy. And the lessons that the Italians have taught us is that really it's hard to keep, it's best, prevention is still the best measure. You can get overwhelmed with the tsunami of clinical disease that hits your hospitals. Worldwide, you see that the outbreak started in China with a large cluster here, but it has spread worldwide. And currently, the United States is experiencing increases in cases, which is not a surprise. Here's thought to be the intermediate host, the pangolin, which is the only scaled mammal, and it looks like an anteater, and has been on the black market for generations. There are people talk about, well, why don't they do something about the wild markets in China and stuff? There actually are regulations to try to control these live markets, but nevertheless, you have a black market where these animals are getting taken from Africa and India and sold on the black market to Asia because they have a long history of some medicinal purposes. So it's difficult to control that, but that's thought to be part of the story. The most important routes of transmission at this point are droplet, contact, and aerosol. But I highlighted droplet and contact because really that's the majority of what we're going to be dealing with. There are no major evidence for vertical transmission in pregnancy, not more severe in pregnancy. There are, 5 minutes ago, a paper was just not peer reviewed, but just put online saying that there potentially are some IgM antibodies measured in newborn babies of a couple of cases as potential evidence of vertical transmission. The youngest case of COVID-2 in babies was in a 30-hour-old baby reported in the Wuhan outbreak. We're going to have more information about that. But to date, there aren't a lot of evidence for vertical transmission. SARS-CoV-2 is found, if you're trying to measure what specimens will likely have the most positive test result, more information is coming. So we have a PCR. That's where a lot of people are looking. We're really not doing a lot of serologic testing. But SARS-CoV-2 is found in BAL, up to 90-some-odd% in one study. Nasopharyngeal over nasal. Oropharyngeal really drops off, even in a known COVID-2 patient. And stool, a smaller percentage. Sputum in one study, 72% reported in JAMA. But honestly, how difficult is it to get a sputum? If you really have to work hard to get a sputum, you're probably going to create aerosol in terms of trying to get them to expectorate, because most of these patients don't have a ton of sputum production. SARS is found on surfaces, so the whole issue of fomite transmission is raised. It is, if you go into patients that have had, you go back into their houses, you can find it on door handles, cell phones, and there is a study looking at how long does it persist on surfaces. It can persist, if you look at old coronaviruses, can persist as long as up to 9 days. Most of the time they report 3 days or less, but some of this depends on the amount of organic material that is getting contaminated. Cardboard's 24 hours, and this is not a virus that can't be killed. It is a enveloped RNA virus. You can kill it with soap and water, and you can kill it with ethanol, 67% ethanol, or a dilute bleach solution, which is online to get the right quantities. Super spreading events, I think, are still important. I mean, if you look at the epidemic in China, their transportation system in 2002 was not as advanced as it is now. And this outbreak there occurred during the Spring Festival. You had millions traveling there for this. This is one of the largest events that China has per year. Wuhan's a major transportation hub. So they had all this activity going on, all this transmission going on. And even by the time they had a quarantine, 5 million people had already left the city. If you want a US example, it would probably be Mardi Gras in New Orleans. New Orleans is accelerating, one of the epicenters in the United States, and Mardi Gras probably did have some impact. There weren't strict restrictions during Mardi Gras, at least people didn't follow them. That's New Orleans. Every one person that has COVID-2 probably infects 2.2 to 2.68. Some of those data in terms of the R naught, which is called, gives you the reproductive number, gives you an idea of how transmissible this agent is. You're going to find differences in studies over time, and it varies depending upon multiple factors, but just keep it in mind that probably 2 to 3 people can get infected with this virus. Currently, this is already old. It was from yesterday, 68,440 cases in the US, 900 deaths, all the states and jurisdictions, and the United States called the state of emergency on 3/13. The Diamond Princess got a lot of press in terms of people who were infected, and the first death was in the state of Washington in January 2020. First death in the US. But here's some MMWR data on the outbreak in the US. This was the Kirkland outbreak that gave us some tips. I mean, one is you introduce it into a high-risk population, you're going to have a bad outcome. So significant number of deaths out of this nursing home. The median age of residents there was 81. Importantly, healthcare workers there were getting infected because basically nobody knew what was going on. So they were passing on illnesses. They weren't as ill as the residents. So nursing home was a perfect place, and visitors also were infected. Now, they don't necessarily need to be infected from the nursing home, but they were infected. So you can see some of when you look at data like this, we're trying to apply it to how do we protect the hospital? How do we protect our patients? That's how you get to some of these policies and saying, we probably got to restrict some visitors. We probably got to look at our healthcare workers, make sure they're protected, make sure they understand that they could be infected as a case or possibly a person that transmits. If you look at the cumulative numbers, it's similar to other outbreaks. I mean, there are models that look at number of cases, any mitigation measures, and what to expect over time. And everybody has really had a similar outbreak curve. China had that first case around December, and they really peaked about a month and a half later, 2 months later. And we're having the same thing. I mean, but it's kind of interesting in the US, if you look at our map, it's not going to be the same for all of us because there are more cases clearly going on the coasts, New York, Washington, and California, and the Midwest will probably catch up over time. Kentucky is not particularly high right now, but over time, it kind of depends on many factors. How well people are social distancing, how well people are, how many potential, what's the factors in terms of crowding, what's the age of your population, et cetera. Another insight where a message somehow gets lost, especially on younger people. So we say the mortality rate is really high if you're over 80 years old. So everybody says, well, I'm not 80 years old. I'm 20 years old. I'm 25. It's not going to hurt me. Well, that's actually not the right message because it's true. If you're older, you will get sick. But a substantial number of people that are 25 or 30 years old are sick. They're still getting hospitalized. If you look at this is US data now. If you're in the 20 to 24 year age group, a significant percentage of you are still getting hospitalized. So it's still affecting you. Here's Kentucky. This is case count as of yesterday was 248. I'm sure it'll be increased today. We have 5 deaths. The first case was reported in Harrison County on March 6th. And if you look at the impact model in terms of the COVID, what happens in there, and that's, I put the reference down there. If you want to plug in numbers, you can see that different people will say that within, probably come the first week of May or so is when we'll see some of the peaking in cases in Kentucky. And that's important in terms of planning for surge, et cetera. How does this compare to other pandemics? We talked about 2009 swine flu epidemic, really affected a lot of people, 61 million people in the US, but it was not as virulent of a virus. So the amount of deaths were minor. And as you recall, the unique story for that is that young people did get infected, did get the outcomes worse. We had a lot of young people on ventilators at that time because they didn't have any history of exposure. If you were over 60 in that outbreak, you actually did better because you probably had previous exposure to a flu that gave you some cross-protecting antibodies. The Spanish flu is always put out there as the marker for the most severe terrible, and it was terrible. I mean, a third of the world's population were infected. Case fatality rate there was higher, 2.5%, but it was not as contagious as this seems to be. So if you look at comparing it to diseases that we're familiar with, if you're talking about Ebola and flu, for all Ebola cases, for all the cases that we had, Ebola, the last biggest outbreak, because Ebola was discovered in '76, but they had the big outbreak in West Africa between 2014 and 2016. Total number of cases was like 28,000, but the significant aspect was 11,000 died. But fortunately, wasn't as transmissible. Flu typically is not as transmissible as this virus is. So SARS-CoV-2 is maybe infects 2 or 3 people. But if you got measles, measles is very contagious. 12 to 18 people will get infected. So how did we deal with measles? Well, we dealt with measles because, again, we have a vaccine that was developed since 1963. So most of us haven't seen a case of measles, but measles does rear its head. And, I investigated outbreaks of measles in the past, and we actually changed our vaccine strategies based on some of that stuff. So it isn't as infectious as some illnesses, but it's more infectious than others. So now let's go into some of this is the virus itself, just giving you it's a new virus. All you have to do is change some components of this virus. This is an illustration of it. And you have a more lethal disease. And that's what happens with a lot of RNA viruses. They do, when you look at influenza, it's an RNA virus, it will change components of itself and take a bird component or take a pig component of the virus and switch it up and cause a new virus that nobody has ever been exposed to before and end up causing significant disease. That is what happened with this virus. We know that it enters by attaching to an ACE2 receptor, and that S protein is important. But those ACE2 receptors are present in the lung, they're present in the GI tract, but also other organs. So where it's probably going to be attaching to, probably has some relevance in terms of its clinical manifestations. So when you look at clinical, again, we're learning new things. The symptoms are not easy to distinguish between a routine cold and other. We know the incubation period is about 5 days. We talked about that. But these patients tend to get sicker, especially if you're older. So fever, non-productive cough, shortness of breath, myalgias, all these are fairly non-specific symptoms. GI symptoms have been a little more emphasized also recently in some of the outbreaks, and it depends on which outbreak set of series that you're reading. You will get slightly different percentages of these symptoms. If you looked at Singapore as well as Zhejiang, China, there's a different they'll report, here's 100 patients, here's 200, here's 300 patients. Some of the symptoms differ in terms of severity. Singapore seems to have had less of a significant serious outbreak. Their patients tend to be less symptomatic. One other symptom that has been noted in the ENT literature, also the GI literature, is this loss of taste and smell, which can be a presenting sign in up to 30% of patients. That is not unusual for a virus, because if you look at loss of taste and smell, it does occur with other viruses like rhinovirus, other coronaviruses, parainfluenza. But if any of you have been sick with a viral illness, you remember kind of feeling blah and not having good taste and smell. But in some of these patients, that's the way they present, and then they get sick. They spike that fever and then have that progression and end up in the hospital. The onset to hospital admission is about 7 days. Some can develop a fever after admission. Progression to ARDS, 3.4% in the Wuhan outbreak, but it may be less over time, usually within 9 days. Those with ARDS have a mortality that's pretty high, at least 50%. You can have acute kidney injury. You can have a myocarditis, an acute cardiac injury. ICU admissions really depend on which series you look at. It can be 5% in one series, 30% in others. It's probably somewhere in between. Secondary infection, there's no article specifically addressing secondary infection, but it's been thought to be approximately 10%. Now, that doesn't mean that they don't get antibiotics, because the vast majority of these patients are getting antibiotics. Severe illness occurs 10 to 16% of the time. And as we get more data on seroprevalence in the community, we'll probably have a broader idea of what the illness is. And I would guesstimate that it's still milder the younger you are, more severe the older you are. Cytokine storm in a smaller percentage of patients with multi-organ failure. So we take that information and how do we use it? We say, we know that there's risk factors for progression of disease, older, comorbidities. Understand that those are the patients that are more likely to progress to having ARDS, respiratory failure. What about kids? Because we, especially as parents, you're wondering what's the spectrum of a disease in kids, and there's small studies published. In general, you take the median age here of 6 years old, good age distribution. 16% of the time they're asymptomatic. They might have mild viral URIs, but if you actually do more close studies in terms of x-rays and such on those young kids, a significant amount of them do have a pneumonia, but not to the point that they're sick. Most of those patients aren't hospitalized. They go home and recover without any issues. They present with coughs. These children representing half of them have coughs, a little bit of a sore throat. Only 41% in this series had a fever. So children seem to have a milder presentation. Up to 10% have diarrhea, fatigue, nausea, vomiting. But a lot of them, in terms of the majority, do not have any problems with hypoxemia. Here's the typical case, first case from Washington, patient from Washington, just to show you what a fairly typical case of a guy who did not get intubated and made it out of the hospital. Subjective fever after coming home from China here, subjective fever, and then really started spiking higher fevers in the hospital that lasted over a week, a cough that lasted 2 to 3 weeks, which is fairly typical, and a long-lasting fatigue. He did have some GI complaints and some abdominal pain. His initial chest X-ray was unremarkable. There's nothing here to see. But after day 9, you do have some infiltrate, but also fairly nonspecific. This is not something that you would hang your hat on. But in the setting of an outbreak, where you have significant numbers of cases, you have to start thinking of COVID. Here's another case from Kentucky, 66-year-old. And the point of this case is he did not come in with the diagnosis of COVID. He came in with the diagnosis of a stroke. So this will happen more often as the prevalence increases in the community, as we see increasing cases. We have to be aware that the STEMI, that the diabetic foot, that somebody with just diverticulitis may also have some other process going on. We have to think about that when we're talking to our patients and screening them for risk factors. His labs were fairly unremarkable, but he was fairly toxic. And if you look at his CT scan, he had some findings consistent with COVID with these more peripherally located ground glass infiltrates. Here's another patient that recently was admitted, 69-year-old from another city, came to Lexington, not feeling well, went to a reunion, and then developed some shortness of breath, non-productive cough, fever to 103. Saw her, her labs were fairly unremarkable, but she was developing hypoxic respiratory failure. And if you look at her CT scan again, she has some of those peripheral infiltrates. But the chest x-ray is not that significant. This patient was COVID positive in terms of PCR. So labs are, symptoms in labs are not that diagnostic. I would say most oftentimes they have a normal white count when they present, lymphopenia, 40% in one study. And there are data saying that certain labs are correlated with bad outcome. So lymphopenia, leukocytosis, elevated ferritin, creatinine, procalcitonin. Again, it depends on what study you're reading. Elevated IL-6, elevated ALT. The median duration of viral shedding is 20 days, but longer potentially in non-survivors. For most people that are in the lower risk groups, it's probably a 2-week illness. It could still be longer in terms of recovery, like some viral illnesses are in terms of just general malaise and fatigue. But if you're sick, you're in the hospital for a long time, 3 to 6 weeks for anybody with severe disease. You can have a persistent cough. And for mechanically ventilated patients, this doesn't fit what we typically look at. If you end up on a mechanical ventilator, this is not easy to predict, like say somebody who has a bacterial infection like Staphylococcus aureus or Pseudomonas. There isn't an easy way to get them off the ventilator. This is kind of an unremitting disease that just continues on and on. You could be on the vent for many weeks, which makes it difficult in terms of management, because the more patients come in with severe disease, the more you're not able to deal with it in terms of your resources. ARDS is the leading cause of death, and there are other causes, including possible myocarditis and probably cytokine storm. So cytokine storm's gotten some more press, and it is a smaller segment of patients, and they usually present with multi-organ failure, fulminant disease, unremitting fever. Have the thought of trying to use anti-interleukin therapies to try to treat these patients. We know from the Italy and also Spain that as you accumulate cases and severity of cases, so in Spain, in Italy, 16% of their cases were in the ICU. It strained their system, it strained their numbers of ventilators available, and made the situation very difficult. How do we make the diagnosis? Clinical suspicion. Now, the epidemiology obviously has changed over time, and it really is a matter of paying attention, first of all, to what's happening nationwide, but also what's happening in your own community. So if we use a strict case definition in the very beginning, it would be only somebody from Wuhan. And then as time goes on, you broaden that definition because you have cases now all over Kentucky, and you have to think about that is going to happen. Examination and routine lab tests really are nonspecific, and CT scan may be helpful prior to your available PCR test. CT scan issue is a little bit tricky because the sensitivity is high in some reports, but the specificity may not be so high. So as we get more information, you might have some crossover, and it depends on which radiologist you talk to. So some radiologists have said, no, this is actually classic for this. Well, if you're in the middle of a huge outbreak and you have that CT finding, its predictive value is much higher than if you're in a rare, you have it rarely and you have somebody positive for some other finding, metapneumovirus, or so. I think there's still more to come. The PCR tests are multiple, and I know there's a whole controversy over availability of tests and such, but if you look at PCR testing in the lab oftentimes performs very well. The sensitivity and specificity high, 90 some odd percentile for a lot of these tests. So that gives you some comfort. There isn't, in terms of specificity, if you have a positive PCR, it does not cross-react with any of the other coronaviruses or SARS or MERS. So they're really paying attention to developing good tests. But remember, it also depends on other factors in terms of trusting that test is giving you the right information. If I test somebody before they even have symptoms and they're way early in their incubation period, I might not have a positive test. If I test a patient incorrectly, I ordered it as a nasopharyngeal swab, but I'm scared, so I'm going to just rub it at the tip of the nose. It's probably not going to be as accurate, and that's clear when you look at different studies. So the quality of the specimen is still very important. We have issues with some shortages. So swabs right now are being held for 72 hours if you do a respiratory PCR to try to marshal our resources. And there is home testing available, but that is a whole separate topic and can't cover it right now. Who do we test for PCR? Now, there's always the gold standard, and then there's what happens at your own local facilities. So same with a lot of these issues, whether it's PPE, use of CT scan, use of whatever the resources you have. The gold standard would be nice to have a test for a lot of people, with the exception maybe of the worried well. But we don't have those resources. So really, we are focusing at this point more on hospitalized patients. And if you're well enough, you're not hitting any emergency room, those patients, because of resource issues, are probably being told to go home and self-quarantine to save those resources for other patients where we think the benefit is better. Hospitalized patients, we're focusing on healthcare personnel who are going to be on the front lines taking care of patients, potentially other symptomatic outpatients at higher risk for poor outcomes. So you talk about your 70-year-old, and it would help you figure that out. But again, not the worried well or potentially an ED patient who can go home and self-quarantine. The test, looks like this for most test kits. It's basically a swab put in a viral media. Viral media is becoming short, so there are workarounds in terms of dealing with some of these viral media, and every lab and system is trying to figure that out. Decreasing the amount, it used to be in 3 mLs, decreasing that to 1.5, looking at normal saline as an alternative media. All that's being worked out by the laboratorians and by hospitals as they deal with whatever their shortages are. But it's a fairly easy test. It's not fun to have that stuck down deep into your nose. You really got to get backwards into the nasopharyngeal cavity. You put that into the vial, you seal it up, and you refrigerate it and send it off. Tests, they all have different characteristics. Most tests, we're trying to get the results back faster and faster. So when we started, we were going everything through the health department. There are more commercial labs available now, and their turnaround time is, of course, is one aspect is what they say the turnaround time is. The next aspect is what actually occurs, because there's a limitation of resource. Who do we CT scan? We shouldn't CT scan everybody. If you have a positive PCR in the hospital, I don't know that you need to CT scan all those people. Probably, especially as time increases and we have increased cases, we'll probably clog up the radiology suites trying to get CT scans. If it really doesn't affect your treatment and you know what the patient has, I don't know that it's going to be that beneficial. There were papers published discussing prognostic aspects of CT scans. I would say an experienced clinician also can tell if somebody's O2 sats are going down and they're requiring increased oxygen supplementation, that CT may not help as much, but that's something to be determined with each facility. So we're tending to focus on hospitalized symptomatic patients. There might be instances where we have incomplete data, and in terms of cohorting and putting that patient in a specific spot, a CT scan might be beneficial, but that's to be discussed. If you're not sick enough to be hospitalized, you probably don't need a CT scan at this point. That may change, and this is an accelerating outbreak. So we have to start thinking about what we do now, and getting a bunch of CT scans as an outpatient, not a good use of resources. Lung ultrasound has been mentioned in the literature as a modality. That really varies on your institution. It's used more frequently in Europe than it is in the United States, but it is could be a bedside modality that potentially over time someone could gain the expertise, and it would diminish their use of alternative radiographic studies. So let's go into treatment. So when we think about treatment, we've got to think about who is going to get infected, what do I expect? Here's the age breakdown from the United States data. So 20 to 44, 14 to 20% of those patients are getting hospitalized. Only 2 to 4% getting in the ICU. But as you get older, you're going to start to use the ICU, and your case fatality rate will go up. So you already have to get a framework in your head about what are we seeing in the hospital, what are our resources, What do I expect in terms of patients? So the younger you are, likely that you will not end up in the ICU, but you're still going to be sick. General treatment points. What do we need to focus on? This is stuff that we've talked about previously, but now it has a little more urgency. We've always talked about length of stay as being important in the hospital. Length of stay is important in this outbreak because we need to protect our patients, get them out of the hospital sooner, as soon as we can. It protects them. It protects us. Consider discharging those patients with telemedicine follow-ups. Choose medicines and laboratories and procedures with the goal of providing the most effective care and minimizing exposure in order to protect healthcare workers and other patients. So think more. This is not the same time where we can order 50,000 tests and a medicine that's given every 2 hours, where maybe a once-a-day medicine would likely have the same effect. We have to think somewhat differently because we're trying to minimize exposure for healthcare personnel to that patient. And don't forget to deliver care to those patients that don't have COVID-19, because there's going to be a lot of patients that still have MIs, that still have other problems, and it is very distracting to have this stuff go on. So we're trying to teach, we're trying to learn, gain whatever tools we can so that when increases in these other patients go, we can handle it. So educate yourself now, because we still have to take care of other patients. These problems won't disappear. Watch for PTSD. So PTSD has been described in a lot of these outbreaks with SARS, MERS, Ebola, where healthcare workers are getting burnt out. It's very stressful to take care of these patients just because there's the unknown. Am I going to get sick? Am I going to get my family sick? What's going to happen to me? We know we have increased stress levels amongst us. We have to build the capacity to have backup and do it now, not wait till we have a ton of cases in the hospital and we're going, oh crap, I'm getting too burned out. So think about building your capacity now for all those measures. Most of what we're going to be doing is supportive care. Oxygen is going to be required in a high percentage of the population, even the younger patients. And ventilator use maybe 6% or more in patients, especially the older and the more risk factors you have. In Italy, 9 to 11% of their patients required ICU care, and ventilators became a scarce resource. And you can model some of this. There are modeling formulas out there, like the CHIME formula for looking at increase in your expected cases, to model how many ventilators you need, what's your ICU capacity, and think about, as we are everywhere in the system, strategies for dealing with ventilators, multiple patients per machine, prone ventilation, a lot of different aspects that the ICU doctors are working on. A high percentage of these patients will be on antibiotics, and it's because it's kind of hard to distinguish who has a viral infection and who has a non-bacterial infection. Over 90%, especially over 90% of those with severe disease were on an antibiotic. Still, documentation of secondary bacterial infections is about 10 to 11%. So it's not really high. If you look at the MERS outbreaks, again, a fairly low percentage of their patients had secondary bacterial infections. And in the MERS outbreak, they also reported co-infections with other viruses. So that's important. Initially, we talked about, well, you could only, if you have a positive metapneumovirus, you can't have COVID. If you have a positive influenza, obviously that, as the outbreak has matured, more articles come in saying, wait a second, that's not true. You can't have co-infections. I can't give you a perfect percentage of that infection, of that rate, because really it probably depends on what's happening in your community. We have an increase in metapneumovirus right now in Lexington, so we potentially could have plenty of patients with metapneumovirus. As we have an influenza outbreak, we're going to have increase in influenza and COVID-19 at the same time. And influenza is treatable, so just pay attention. When you look at critical care, I guess the message is they're more likely to progress and need ventilators. So ventilators sooner than later. You want to do, when you put somebody on the ventilator, you want to put it, they want to put them on, and I'm paraphrasing all the expert, ICU doctors, not myself, but I haven't intubated for quite a while. But you want to ventilate, you want to put them on ventilators sooner than later. You don't want it done, you want it done in a controlled situation because if you want to protect yourself and protect others, you really want to do it in a controlled situation. You know how to use the PPE correctly. You don't want to, remember what we talk about in a code. When you went to a code and you tried to teach residents, you take your pulse first and then you address the patient, because if you're out of control and running around with your hair on fire, bad things happen. So consider early invasive ventilation. Airway treatment of the airways is important. So some tips from different articles would say earlier decision to intubate under controlled circumstances using rapid sequence induction to prevent coughing or vomiting, and rapid cuff inflation to avoid leakage, and establish protocols now and practice if you can with your code blue teams, because the code blue, I mean, this has still happened. We've had code blues on patients that are suspected to have COVID, and it doesn't always go that smooth because, you know, people are looking for their PPE, they don't know what they're doing, and there's certainly an increased anxiety level amongst practitioners when that occurs. Steroids are not helpful to date. It is ongoing clinical trials. If you look at previous information regarding SARS and other viral illnesses, immunocompromised hosts and those treated with steroids tend to shed virus longer. There are some information saying it exacerbates pulmonary toxicity of COVID, but there may be a small role for steroids in those with cytokine storm or shock if they need. That is one of those things that still needs to be studied. Now, there are no approved medications to treat, but many are under investigation. And remember, this outbreak is also interesting for me that it's an outbreak of literature. It's probably the biggest outbreak of non-peer-reviewed literature in the history of medicine. You have a lot of articles that are out there, probably thousands and thousands. The studies that are being reported right now are small numbers, so they get conflated into major treatment decision or systems. And I think we do have to be careful. We're caught between the panic and the fear and the anxiety of trying to treat, but at the same time, there is a role for trying to come up with data to see whether or not we're doing the right thing. So hydroxychloroquine plus azithromycin, which personally I don't think has that much of a benefit right now, lopinavir, ritonavir, remdesivir, et cetera. A lot of these things in convalescent plan, I'll touch on a few of these. Vaccines are under development. I mentioned that there was vaccine development for MERS. MERS is still, trickling. It's not a completely resolved infection. So they were in the process of studying MERS vaccines. So many companies involved in clinical trials. And then cytokine therapy versus interleukin 1 and 6, especially for those in cytokine storm. So let's look at just two quick things. This is the level of evidence. So we have a lopinavir ritonavir trial reported in the England Journal, 199 patients, no difference in mortality at 28 days or viral load. But again, it's a relatively small study. It's not powered potentially to detect a major difference. So, grain of salt. Hydroxychloroquine and azithro as treatment for COVID, non-randomized open label trial. Again, we're pushing out a lot of hydroxychloroquine. And there's some reason, because it does have in vitro activity, which is great. If you look at the curves, it really does knock down the coronavirus. But in terms of clinical data, a lot of the recommendations are made based more on the in vitro and a hope than a large clinical, because we're talking about 20 patients, of which 6 used azithromycin. So I would take that with a grain of salt in terms of saying, and there is potential toxicity. These drugs are not completely benign. If you give hydroxychloroquine and azithromycin, then the patient has already a very long, prolonged QT, that can lead to some misadventures. So we need to continue to study that, at least in some kind of fashion, to get better data. Immune modulators, similar story. We are talking about IL-6 treatment, and there's, if you can say this word, your tocilizumab. It's really a tough one to say, but an IL-6 inhibitor. Now, the thing is, we have some experience with this medication in previous outbreaks. So SARS was looked at for It was looked at in terms of using it, I guess, for potentially MERS, and also it's been approved since 2017 for rheumatoid arthritis and some other inflammatory diseases. They have a protocol in place to look at it. So there is some reason to participate in the protocol, but in terms of rolling it out as a nationwide treatment, I have a little more skepticism. If you're going to do it, some of the measures to look for the cytokine storm would be measuring IL-6, ferritin, platelets, C-reactive protein, procalcitonin, and fibrinogen levels, if you can spell that right. But it's still within a protocol setting in terms of using it. It's hard to know whether IL-6 is the driver or it's the consequence. If it's the driver and use an IL-6 inhibitor, potentially it has a benefit. If it's just a consequence of having uncontrolled infection, then I don't know. And in terms of clinical data that's available, again, a fairly small study, 20 patients. So 15 out of 20 patients were improved, but that's only 20 patients. So it's hard to give you big recommendations based on that. Convalescent serum, ongoing evaluation. Again, not a lot of published data. From previous outbreaks, there was a meta-analysis done in JID in 2015 looking at SARS outbreaks, MERS outbreaks, Spanish flu, and swine, just pulling together data that was available. And it's very difficult to do that kind of meta-analysis. All the studies are done somewhat differently. But the concept is valid. It has worked in other illnesses. It worked for Ebola. It did have a benefit in terms of mortality when they pooled the data in these diseases. Now, this is not SARS-CoV-2, but this is other diseases that are fairly similar and gives the concept that makes sense. But there's some caveats. It didn't really decrease critical care support. So you're still got sick patients. And ICU stay didn't change that much. Hospital stay, though, might have improved some. And if you were to gather any information from that paper, it was that using it earlier than later is important. In terms of using it in the setting of this outbreak, it's been mentioned, there are potentially, if we don't come up with better treatments, thoughts about using the blood bank but it requires a system of working probably through public health and registries about who is convalescing. We don't really have all that stuff rolled out. We're going to have to look at a serologic test that's widely distributed and then figure that stuff out. But maybe that is an avenue that will go down. Now, Dr. Barton's here, so I don't want to, I was going to just touch base on a few things. One is, I'm just summarizing some of his points that he had told me about prior to, he is here, so he'll clarify some of them if I misspell. Similar concept in terms of length of stay, minimize the time for the patient in the hospital. So in the setting of OB, it means utilizing scheduled C-sections and earlier discharge if stable, limiting the use of antenatal steroids beyond 34 weeks gestation, have an eye to managing, instead of conservatively managing premature rupture of membranes, to proceed faster with the treatment of those patients, and review elective inductions in terms of the pros and cons, because again, it's with an eye to, if I'm doing something and the patient still ends up getting a C-section, probably cut to the chase and do the C-section sooner. And then minimize exposure of healthcare workers to a potentially infected patient, and that one recommendation coming out saying avoiding active pushing in the second stage of labor if the fetus is okay. So we don't have good treatment yet. We have some marching along trying to think about treatments. We know we have oxygen supportive care, potentially using some of these agents. So we're using public health measures to deal with the outbreak, and that's identifying cases, isolate cases, and treat. And then we're applying that to our facilities. So we're still doing those things. We've had progression of those measures as we go along in this outbreak. We are screening patients. In some hospitals, they are screening staff as they come in, and we are screening visitors. We're trying to encourage patient portals, reevaluate who actually requires an in-person evaluation. And then in terms of protecting healthcare personnel and patients, focusing on protective equipment, the PPE, N95s, the gloves, the masks, and hand hygiene. Engineering controls we are creating in every hospital is looking at their setups in terms of potentially creating wings that are negative pressure. And administrative controls such as the visitor policy, which has been now enforced in different areas, but essentially decreasing it to no visitors, decreasing movement, cohorting patients, trying to limit face-to-face encounters, limiting length of stay, canceling elective procedures, which was done around the 18th of March. Now PPE is controversial. I mean, it's a little bit different in every facility, but there are some basic measures that we're still trying to focus on. And people sometimes get confused and they say, well, you know, we're doing it slightly differently. But remember, there's a couple of things. One is if we do PPE correctly, whether it's using a mask, and we recognize the highest risk procedures, any aerosol producing procedure is a thing to focus on, you will be protected. Even though 20% of people in Italy, healthcare workers, got infected, 80% did not. And they were in a storm of COVID-19. And the lessons for those things are typically, it's a breakdown in PPE, it's correct use. It's, and if you're talking about Wuhan, they were completely swamped and they didn't have any PPE. So doctors were going in there seeing patients with no PPE. So if you don't use PPE, you will get sick. But if you use PPE correctly, the likelihood is that you will not get sick. So focus on aerosolized procedures. And in that case, we're using N95s, airborne, gown, glove, and goggle. Patients with, face shields too. If you're talking about resource scarcity, again, COVID patients that are in shock or on ventilators are going into airborne precautions, N95s and PPE. We're trying to minimize contact, and we're using technologies that are out there. This you don't have to have a big machine to go into the rooms. Use a cell phone. I mean, and I would push forward that any facility that hasn't started to acquire other technology, because you might not be able to get a hold of iPads, use an inexpensive video technology. We got to be able to deal with that now. I would start purchasing those now to be able to decrease the amount of contact. There are lots of different measures, for example, using long IV poles and stuff like that. Those are all good thoughts. As you go through this whole process, there are so many facets to the delivery of healthcare in a hospital. We need everybody's input, OB's input, ICU's input, hospitalists. Every section has their focus and has their expertise. And not everybody can have that all together. It's a time to come together, whether it's facilities or whether it's, different parts. We all got to share our knowledge to try to make things better, because we are trying to use best science and best evidence, common sense, and try to go forward to improve outcomes for our patients and to protect ourselves. We are looking at surge protection. Repurposing ventilators, looking at how we're conserving our own PPE now, and if we need more PPE, as that's going on. You've heard all those stories about contracting with local businesses to try to create face shields or whatever the circumstance might be. Looking at our strategies for sick leave, cohorting, and communication, which is vital and can always be improved. It's still one of those things where this is an incident command type of healthcare. This is like a war to a certain degree. It's not always, we don't have 10 weeks of gathering all the data. We have to try to make decisions with what we have now, with what best evidence is now. And if you go to different websites, or you'll see MGH, Mass General, might be doing something differently, Cleveland Clinic's doing something differently. They're all trying to deal with the situation the best way they can with what information they have and what resources. And not everybody has the same resources. Believe me, Cleveland Clinic has better resources than some other hospitals do. But we are every day trying to figure out how to make things better, and we need people's input. There are daily meetings with stakeholders. There are system meetings. There are meetings within the city where we're trying to have UK and the Catholic Health initiatives and the Baptist system really trying to pool understandings of how to deal with these patients, how to deal with our resources, and move forward. How do we prevent spread in the hospital? We are still working on identify risk factors. If, for example, you're in some facility and you're a cardiologist and you get a direct admit, but you don't really think about it because it didn't go through some kind of screening process, you could potentially harm yourself and harm others because they're going to come in with other things. They're going to come in with an MI plus potentially COVID as the outbreak increases. So identify risk factors, follow your guidelines. Remember, in general, when they do studies looking at in SARS and MERS outbreaks and looked at healthcare workers, when healthcare workers followed procedures and used PPE correctly, they did not have a high seroprevalence of conversion to these illnesses. They were protected. So we can deal with this if we really follow what's been out there and what's been developed. That means we got to wash our hands reasonably. If you wash it, rinse and shake, which is basically a lot of what a lot of us do because we have a large patient load and then we're just going to the next patient. You're not really removing that much versus if you do it longer. And we recommend 20 seconds. That's singing your ABC song twice or the song of your choosing. Donning and doffing of PPE. Remember, if you have PPE, you got to use it the right way. If you don't use it the right way, you will potentially get infected. And that was the same story for every outbreak. For example, Ebola. When Ebola workers got infected, it oftentimes was a breakdown in how they use the PPE. And there's so many ways. I say, don't touch your face, but I probably touched my face already, 3 times during this presentation. So we got to try to stick to paying attention. That's why in terms of right now, where we're at in the outbreak, increase your educators in those areas that might not even have an outbreak yet, but because you're going to get cases. So increase that education. Practice before it happens. It gives them more confidence in terms of correct use of PPE. It gives the facility more confidence, and you're moving forward. So when you talk about infection control and difficulties, they've studied this. This is so complicated it makes your head want to blow off. But there are many difficulties. People will. That's not the point. There's a lot of difficulties. It isn't always that clear. Ask a question. Try to and we'll try to roll out good educators. We know it's not always that easy, and in fact, things do change over time because resources change over time. So CDC might have a recommendation, and it changes slightly, and they've had to make modifications because it does matter somewhat on the resources. That's okay. That's just the way it is. A lot of times, again, in medicine, we have to do things with not always the perfect setting to make it work. In your clinics, you still got to identify risk to patients, but I would emphasize try to transition to telehealth if you can do that. Because many of our patients that you see in follow-up, they may not need to be seen. And transition to telehealth, I think that's going to be important at least for the next year, not just for weeks. So it's reasonable technology to invest in, figure out how to make that work. Isolate patients if they come to clinic sick, put a mask on them, put them in a private room, and then contact the public health department, and the numbers are there. Remember that behavior matters. This is the famous slide from the Philadelphia, September 28th, 1918, right before they had 100 some odd cases before, and then in 3 days later, this is during the Spanish flu, in 3 days, every 37 hospital it was basically full of patients with the flu. How is Kentucky doing in terms of its social distancing? Well, there is a way to figure that out. Apparently, every time we use our phones, we leave a signal. So people are collecting that data. And so they can tell based on your previous measures of distance using GPS of whether you've decreased your amount of distance used after a concerted efforts made to enforce social distancing. So we get a B so far, and I think that has helped us. It is, if you look at New Orleans, they did not get a high grade, and it has a consequence. I think but you got to still be vigilant. I was driving yesterday. It was a nice day. It was 70 some odd degrees, and there was a ton of UK students all over the place. They're just getting together. It's nice to get out of the house, but we got to emphasize, especially to our younger students and younger, that they've got to pay attention. It's part of your social responsibility to help us negotiate this the next month or so. If we're able to do that, there are lots of different models, but we want to be on the red curve, not the blue line here. Because if with increase in social distancing and following some of those social behaviors, we can actually decrease the spread of this disease in the community and allow us to continue to build capacity in every hospital and deal with it and not have to deal with some of the bioethical decisions that are, we're currently talking about. Who gets a ventilator? Who gets into the ICU? Those are horrendous decisions that we may be forced to make in the future, and we're trying to avoid that. If you have questions, these are your contact numbers at Baptist. Every hospital has, oftentimes has a connection with infection control. Try to get familiar with them. And there are phone calls. We're trying to meet as a group of physicians and infectious disease in the state with a call. I know all the administrators are meeting as groups in their systems. So we need to continue to work toward that. And with that, I'd like to turn it over to John Barton. Thank you.
I'd like to provide a short update on the coronavirus and the obstetrical population. And there are really three main questions that people are worried about from an obstetrical standpoint. One, are pregnant women more susceptible to COVID-19? Two, if women become infected with coronavirus, are they more likely to have maternal or fetal complications? Or three, is there an impact on the newborn? Now, the simple answer to all these questions is there's limited number of publications in peer-reviewed journals that direct our counseling. And many of these papers are now being expedited for publication, some with less than great review. So as far as point number one, are pregnant women more susceptible to COVID-19? There was a paper from the Lancet in March that reported 9 women from China who tested positive during their 3rd trimester. None of these women had severe infections. The virus was not found in the amniotic fluid or in cord blood of any of these pregnancies. Now, an hour before I came to this conference today, there was a case report published online from New York of 7 patients with COVID-19, 2 of which required ICU admission for respiratory issues. And you think, man, this is pretty terrible if 2 out of 7 are going to the ICU. But again, here's the key. This was an expedited paper, and in the 30 minutes I had to look through it, the first case was an uncontrolled postpartum hemorrhage at C-section that required intubation. And then while she was in the ICU, she turned out positive PCR for COVID-19, but she also went home on postpartum day 4. I find it hard to believe that she had a severe COVID-19 infection. So the question was she intubated because of an obstetrical complication? And incidentally, we found COVID-19. The other patient that had respiratory complications had severe preeclampsia and pulmonary edema and blood pressures of 200 over 90, and then incidentally was also positive for COVID-19. It was well by day 4. So this is the issue in the literature, is what are co-infections and what are true infections? Now, as far as women who contract coronavirus during pregnancy, any pulmonary infection during pregnancy, particularly in the 3rd trimester, carries an increased maternal risk because of the altered respiratory dynamics of pregnancy. Their diaphragm is elevated, they have changes in tidal volume, they're at increased risk when they have these respiratory infections. And any infection, regardless of what the site, during pregnancy carries an increased risk for preterm delivery. Now, and the main reason that I got involved today, there were 3 reports that came out yesterday concerning COVID-19 in pregnancy, suggesting a potential vertical transmission from the mother to the fetus. Everything up to this point has suggested that there was not vertical transmission. But in the one publication that came out yesterday afternoon online, 33 babies, and these were all babies born in China, to mothers who had COVID-19 that were infected. The babies weren't tested until they were 3 days old, which is a little concerning. I'm sorry, until they were 2 days old, and 3 of those infants had elevated IgM antibody suggestive of an intrauterine infection. But most importantly, none of them had reverse transcriptase PCR testing, which would be more definitive from a virologic evidence of congenital infection. So in the previous studies looking at IgM and COVID virus, most cleared it by 14 days. So the real question is, and IgM doesn't cross the placenta. Was this a true intrauterine infection or some consequence of infection after the birth? And then when you compare other IgM studies in rubella, that tends to remain positive for 1 to 2 years. And then Zika virus, what we had 2 years ago, the IgM tends to stay around for up to a year. So in summary, is it possible that COVID-19 could be transmitted in utero? The answer is yes. But without virologic evidence, I think you have to say the risk is somewhere between 0 and very low. Now, we talked about some of the issues specific to labor and delivery to minimize the risk for transmission. And I think the important thing that we need to do as providers is to minimize the time these patients spend in the hospital and to minimize the exposure of potentially infected patient to healthcare workers, particularly our nurses. And Dan showed a few of the comments that we've come up with and potential ways to do this. I think we need to be very careful with our use of steroids for enhancement of lung maturity, particularly after 34 weeks, because with the steroids, we need to avoid suppressing the immune response. I think when possible, don't encourage active pushing during the second stage of labor. Let these patients labor down, because as they push, they're more likely to expel secretions that could carry the virus. And then we tend to have this philosophy of oxygen is good. So if we see variable heart rate decelerations or intermittent late decelerations, to provide oxygen therapy to the mother, all we're doing is potentially aerosolizing the virus. So unless we have a really strict indication for oxygen therapy, maternal saturations that are low because of pulmonary edema or some underlying maternal complication, really trying to avoid the use of oxygen therapy for simple variable decelerations in the fetal heart rate. We made the point that we shouldn't cancel scheduled cesarean deliveries as long as there's an appropriate indication and it's performed at the appropriate gestational age. We're bringing these people in, we're getting them delivered. Hopefully we can do early discharge at day 2 and minimize their time in the hospital and their exposure to the healthcare workers. As far as elective inductions, the ARRIVE trial shows that we're not artificially increasing the risk for C-section by doing an induction, but I think it's very important that we assess the Bishop score for these patients. If they have a very poor Bishop score, yes, ultimately we can get them delivered, but is it worth taking the risk of a 3 to 4 day induction to ultimately get this patient delivered when there's not a true obstetrical reason to proceed with the delivery, and that by maybe being patient, the Bishop score would improve and we can shorten the time that the induction takes place. Now, by all means, if you have maternal or fetal indications for the induction, then that should proceed on. We're working on some recommendations for obstetricians about how they can alter some of their management as an outpatient preeclampsia, spacing out some of the antenatal testing, spacing out some of the ultrasound imaging times to minimize the risk for interaction between the patients and the healthcare workers without reducing adverse effects for the mother or increasing perinatal outcome. So that's all I had. I'll be happy to answer any questions with Dan or Mark.
Yeah, why don't we can take a few questions next week. I anticipate that we'll have more questions because I'd like to have this presentation online so we don't have to go through everything, because at this point I think people have heard some of these things. We'll just focus on more new things and then answer some questions. I think that's what we'll do next time, say in a week and a half or so. So we can take a few questions and guys can answer. I'll point them out. Here's a chat. Fishbone diagram is important. Healthcare workers do not need another video. It is difficult. They need a spotter. I agree. So from my perspective, education is important. It is, especially when we have had changes over time. So in investing in spotters and educators, especially at points of where you know you're going to have a COVID unit, cohorting unit, practice that now, and practice it now because I think it'll yield results in the future. Go ahead, Mark. You want to say something?
This is Mark Doherty. So as you may have noticed, it's a little bit difficult to do these presentations because we're still trying to socially distance ourselves. But we're actually stationing educational nurses on the units where we have most of these patients, and we're going to probably have a heavy presence there. It's very important for us to go over donning and especially doffing repeatedly and over again. So we're diligently working on that right now.
But let's do it before. See, like we have some cases in the hospital, so we're focused on it at all the local hospitals. Even if you don't have a case, I would suggest you get people out there and just start practicing, because really getting your level of expertise and comfort is going to be important.
The only advantage of having a slowdown in testing is that we've gotten a lot of practice in patients who don't have it and donning and doffing, even though that's resulted in wasting some PPE. So I kind of look at that as a little bit of an advantage we have, and partly mitigating the negative part of wasting the PPE.
All right, I think we'll close it up unless there are any other questions right now. This has gone a long time. We appreciate your attention, and hopefully you got something out of this. Remember, we're all in it together. The audio and the video may not be perfect because WebEx isn't perfect either. I mean, WebEx is really probably getting more traffic than they ever gotten in the history of WebEx, but it is new technologies, and it hopefully gets better over time. But I appreciate your time today. Thank you.